Hola a todos, ¿cómo están? Buenas noches. Muchas gracias por acompañarnos el día de hoy, donde la Sociedad Chilena de Medicina Reproductiva ha organizado un webinar que toca temas de salud reproductiva masculina, que no es algo tan común en la Socmer. En el webinar de hoy tenemos una gran invitada. Ella es Cristina Wang. Yo conozco a Cristina hace varios años. Ella es una de las personas más importantes del mundo en estudios clínicos de fertilidad masculina y sobre todo métodos anticonceptivos masculinos. Ella trabaja en el Instituto Lundquist de California, es profesora de UCLA, ha estado involucrada en la creación de los manuales de la Organización Mundial de la Salud para análisis del semen humano. Y ella hoy nos dará una charla corta y concisa acerca de los métodos anticonceptivos masculinos, tanto el pasado, el presente, como el futuro. Esta presentación será en inglés. Ustedes pueden hacer las preguntas que tengan, escribirlas en el chat y yo se las puedo hacer a Cristina. Y posteriormente yo daré una pequeña charla acerca de qué ha pasado con la fertilidad masculina, por qué la calidad seminal se ha ido deteriorando a través de los años y cuál es su asociación con otras enfermedades como el cáncer testicular. Ahora voy a hablar un poquito en inglés para poder decirle a Cristina que ya puede comenzar. Well, Cristina, we are ready for you. I just introduced you to the Chilean public. So if you want, you can start sharing your presentation and I will put it here.
Oh, I need to move this. Okay, is this okay?
No, I'm not seeing it.
Huh, how come? I did the same thing. Okay, let me go out. Sorry about that.
No, don't worry.
Present. I do. Oh, here. So let you share. Okay, I say share and it's not responding to me.
That's weird. Yeah, I'm not seeing your presentation here.
Yeah. Let me cancel and try again. Yeah. Let me try again. Sorry. Your browser has blocked your screen.
Don't
Click
worry.
the screen icon in your address bar to allow access. Reload page. Wow. What happened? So let me try again. Share screen. It's not allowing me to do it. Share screen.
That's weird because we tried it before and it worked.
Yeah. It does not allow me to click on the share before. They want me to. They do not. It does not allow me to share now.
Okay, Cristina. Maybe if you want, can you send me your presentation?
Sure, I'll send you your presentation.
Yeah, send it to my email, please.
Right away, okay. It could be that my thing is blocking me. I don't know. I send it to Gmail. Or
Yes, yeah, you can send it to my Gmail.
the only problem is that it may be very big. That's the problem. Attached file.
Is it big?
Mm-hmm. Only 6 megabytes. You think you would do
No,
it?
it's okay. Perdón por el problema técnico, lo estamos solucionando rápidamente.
They want me to go in and try again, or did you get my email?
Yeah, no, not yet. I received your email that I am on, but now. Okay, give me a second. Okay, I just sent it to the organizer. She will upload it.
We apologize for this. Yeah. We tested. It was perfect.
Yeah, we tested before, and now I don't know why it's not working. Ténganos un poquito de paciencia. Bueno, como les decía, Cristina Wang es una de las personas más importantes en los estudios de fertilidad masculina. Ella ha estado involucrada en la creación de los últimos 2 manuales de la OMS de análisis del semen humano. Y ella y yo hemos estado involucrados en el estudio más avanzado de anticoncepción hormonal masculina, que me imagino que va a mencionar en su charla de hoy. Así que denos un minuto que están subiendo la presentación. So they should be uploading the presentation. One second. Se está subiendo. Ya, ahí está. So, Cristina.
Okay.
Let me. No. Okay, Cristina. I will leave you to your presentation. I think I have to. Are you able to move the slides?
Let me see. I'm sure. No.
No, there is in the screen. There is like some arrows. You're not able to click on them on the slide.
No, I can't see them. I can see yourself, myself, and then something here, which I think is how big the screen can be, and that's it.
Okay, I will do it. There's
Okay.
no problem. I will do it. So I will.
I really apologize for this. We tested
No.
before, and I
Don't
want
worry.
to thank Dr. Renee, and also it's a privilege for me to speak to the Chilean Society of Reproductive Medicine on the topic of male contraception. Next slide, please. So what this is my disclosure. There is only that we are supported as Jose is by the National Institute of Health and the National Institute of Child Health and Human Development, and you know that we have lots of problems with that at the present moment, but this is what we plan to do. So next slide. So this is my outline, and I won't spend time in it because we are going to move forward because we have. Sorry about that, wasted some time. So we will talk about why do we need male contraception. Next slide, please. So this slide shows that these are the typical effectiveness of contraceptive methods. And if you move the green arrow from the lower part to the upper part, you can see the contraceptive efficacy is obviously most effective with non-reversible method, including vasectomy or female sterilization. But however, you should also recognize that the continuation rate of like reversible type of female contraception is only about at best about 60%. So there's in fact a lot of room to develop new methods. So the male methods are not designed to replace female methods, but they are complementary to the female methods. And as you all know, at the present moment, the male method is restricted to vasectomy, which is presented as a non-reversible method, and also either the male condom or withdrawal that have a very high failure rate. Next slide, please. So when we when studies are done that was funded by the Bill and Melinda Gates Foundation, and done by this foresight development, they went into 7 low to medium, moderately low income countries, and they went and asked that if you have a new method of contraception, are you going to be willing to do it? And you can see from the line there, the purple and the blue line are the highest, and they reach over 70%. That the people are, the men there are willing to use a new method, and within 1 year of approval, and that reaches about 90%. Compared to the purple line you see right at the bottom, which is only around 30% in the US. As time goes on, would they ever use contraception? In many of the countries, we reach over 80%, close to 90%. And you can see that these are done in Africa and in Southeast Asia, and the results are essentially the same, because the men in Nigeria and Bangladesh welcome a new method. The next slide, please. It shows what they prefer. So when you ask people in Kenya, Nigeria, in the Coast of Ivory, Vietnam, Bangladesh, and the Democratic Republic of Congo, you can see that most of them prefer a gel. Sorry, I don't know why you can. It's the transcription. Yet all of them are transdermal methods. So the thing that is circled that they most prefer, number one, in fact, are transdermal methods. And it may be biased because at that time we're introducing the gel in Africa, and maybe they heard of them. But the number one preferred method is a gel, something that applied to the skin, so that they don't have to take a pill every day, except in the United States. Next, please. So what about a female partner? This slide shows the female partner, that if my partner told me that he was taking a contraceptive, I would believe him. The two greens indicates that they agree or they strongly agree. In other words, you can see that at least more than 50% of the women, and in some countries very high, would trust the male partner taking a pill or a gel or whatever to suppress fertility, and therefore this indicates that both the male and the female are consider that male contraception in fact is a good method. So this shows in fact that it will be acceptable to many people in many countries. Next slide. The next slide shows that we believe, and I think this is correct, that the current male methods have either very high failure rate, or that it is presented as irreversible. So we believe that a number of male contraceptive methods should be available to men to meet the needs of different cultural and ethnic background, and that the targeting of the hypothalamic pituitary and the testes or the axis is what we call hormonal male contraception, and it has gone furthest along the developmental pathway. Although many other methods that target testicular and post-testicular sperm maturation, production, and fertilizing capacity is being investigated, as well as new vas occlusion methods. Next. So why do we want hormones? Next slide, please. The issue is that we know how hormones work. So on the left-hand side is the normal hypothalamic pituitary and the testis axis, showing that the in men the hypothalamus secretes this hormone called gonadotropin releasing hormone, which acts on the pituitary to produce two hormones, LH and FSH. This gives rise to a very high testosterone concentration within the testes, and this supports spermatogenesis. And the male hormone is also secreted out to maintain the action of androgens on the male. So when we use a male contraception, either testosterone alone or testosterone plus a progestin, we shut off the production of gonadotropin releasing hormone from the pituitary. We shut down LH and FSH, and very importantly, we shut down the production of testosterone within the testes, which will shut down spermatogenesis. But that has a problem because then the men do not have the testes producing testosterone, and that is compensated by the exogenous testosterone that's given to the man so that the peripheral in the circulation the testosterone is normal, but within the testes the testosterone is very low, maintained very low, and therefore spermatogenesis is maintained. Because we know how hormones work, so we're very comfortable in giving hormones because we know if you take them away, they are reversible. Next slide. So testosterone, all of you know, that has been used for many years, for 70 years, and just recently in 2023 there was a huge study of 7,000 older men to show that in fact the testosterone is very safe. There has no additional cardiovascular effect, and unless you have prostate cancer already, it really does not do anything to your prostate. And the progestins are components of hormonal female contraception, has been used for many years and has proven safety. So the good thing about hormone is that we know the side effects. When we know the side effects, we know that we can monitor. If you have too much testosterone, you may have acne, oiliness of skin, weight gain, maybe mood changes, some changes in sexual function, increase in hematocrit, and some um, um, uh, uh, changes in lipids, usually that are not clinically significant. And in the clinical trials has been done on hormonal male contraception, is the the adverse events are rarely the cause of discontinuation, and very few serious adverse effects. So we are very comfortable in using these hormones in younger men. Next slide, please. So how effective it is, and it has been shown, next slide, in the studies that were done by the World Health Organization in 1990 and 1996. In the two studies, they asked if you induce azoospermia by using testosterone injection that was given every week at that time, would it provide protection as against pregnancy in a female, in other words, as a male contraception? Then they changed this. Once that was successful, we went ahead and did the second study, which is if you suppress the sperm concentration to very low level, oligospermia, would it be efficacious as a male contraceptive? The next slide shows it is, and this is published in Fertility, next slide, Fertility and Sterility, which shows that if you suppress the man's sperm count to very low levels, less than 3 million in this WHO study, remember most of the men in fact are suppressed to azoospermia, the overall Pearl index, or the pregnancy rate per 100 years, is 1.4, which is equivalent to an injectable female hormonal contraception and better than an oral contraceptive or the transdermal. But this is an injection. So they show that if you suppress most of men to azoospermia and the rest are severely spermatogenesis severely suppressed, you get a pregnancy, failure of pregnancy protection, which is like the female methods. Next slide. And this has been validated by large studies. You can see the two World Health Organization study using testosterone inactive, followed by two studies that were done in China by using testosterone undecanoate injections. And you can see that the overall pregnancy or failure rate per 100 couple years is usually around 2 or less than 2, which is acceptable because it's really similar to the female female hormonal contraceptive failure rates. Next slide. So what are we going to do? Because what we wanted to do already showed that in this phase 3 studies in China, that if you use androgens alone, you can do it and suppress sperm count to near zero in most of the men. Next slide. But in non-Asian populations, sometimes the suppression of spermatogenesis is not as efficient. So it has been determined that we should add another compound that will suppress the production of GnRH, LH, and FSH, and that is the progestin. Progestin, as you know, are in female contraceptive methods and has been used for many years. So the thing is that if you add the progestin, you increase the rate and the extent of spermatogenesis suppression. And also, if you use the combination of androgen with progestin, it reduces the dose of androgen that is required to achieve contraceptive efficacy. The problem always have a con is that you may have more adverse effect than androgen alone, and the combination regimens are sometimes more complex, and that you have to worry about the steroid combinations, the formulations, the pharmacokinetics, and the dose levels. But the aim is to add an agent, a progestin to androgen, so that the dose of androgen can be lessened, and that also that adding a progestin will be much more efficacious in suppressing the hypothalamic pituitary axis. Next slide. So this was done in a WHO-sponsored study, and that was published in 2016, and they used testosterone undecanoate plus norethindrone enanthate. They recruited 320 men, and you can see again the pregnancy failure rate is very low. So it's comparable to the testosterone alone regimen, the 4 regimens as shown before. And as most of you know, that this study was stopped. Most of us believe that this is stopped prematurely, and it is mainly due to side effects limited in one center, but it taught us a lesson that we need to monitor the participants carefully and make sure that we recruit men that do not have significant illness, including mood changes, including depression. Next slide. So what we are doing, the other thing that people always ask is that if my sperm count is suppressed to zero, will it recover? And the next slide shows a study that Dr. Peter Lu did when he was a trainee here with us, and he's now a faculty. It shows that in the green line shows that if you recover to 3 million, you're going to recover to 10 million, and you'll recover to 20 million. And you can see the white line that will they recover to baseline? They would. But in all the protocols, even up to now, as soon as the man reaches the lower limit of null range, we let them go. So in other words, that's why you have to show the slide. The graph is slightly lower, but unless something happened during the period of time, we believe if not most of them, and in fact most of them, unless they have something going on, that all of them will recover from hormonal male contraception. Next slide, please. So what are we doing now? Next step. So we want to have, so the studies have been done on injectables, and we want to use something that the participant can control, like orals, transdermal, and we are trying to also do long-acting injectables, like maybe at least 3 months, 6 months, or 1 year injectables. And then we, so one and in the NICHD, or National Institute of Health, have some modified androgens that act both as an androgen and a progestin, and those we are still studying, and we hope that we can have two compounds within one chemical property, so that one chemical um, um, agent has the two properties. So that is being developed in phase 1 studies, and we have not gone on a phase 2 study. But so the studies that we initially did was on safety and tolerability. Next slide. Next slide. So this is the group that works on. It's called a Clinical Contraceptive Clinical Trials Network, and it is funded by the National Institute of Health. And for the study that I'm going to talk about, it is also it is also sponsored by the Population Council, who has the patent to Nastron, and it's us here in Los Angeles and Dr. Stephanie Page and Bremner's group at University of Washington. So this is the male clinical trials network, and you can see, next slide. And so we then decided to use a transdermal preparation, because transdermal testosterone up to even now is the most popular method of contraception that's used by men for androgen replacement. And then the Population Council has this very, very potent nastrone that they have shown in females that it can be administered transdermally. So on the slide, on the bar graph on the left, shows that we use a fixed dose of testosterone increase to find out what is the dose of nastrone we need. And in that study, we show that 8 milligram is in fact the highest dose we use, is the most efficacious. Then we went ahead to do a 6 months sperm suppression of sperm production. This means the men apply the gel every day for 6 months, and we measure only sperm concentration and sperm function. And what we see here is that we use a fixed dose of testosterone, again 100 milligram, and we use no nastrone in the white line, and the nastrone 8 milligram in the blue line, and nastrone 12 milligram in the yellow line. First thing you can see, as soon as you put the nastrone together with the testosterone in a gel, or two, and in this case, the gel was applied at 2 areas, it caused a marked and very quick suppression of spermatogenesis. And that is maintained throughout the period when the man applies the gel. The slide also shows that increasing the nastrone to 8 milligram really does not need to do that. And it's based on this study that we went to our phase 2B study. Next slide, please. So we have a phase 2B study that have a screening phase of around up to 24 weeks, an efficacy phase where the couple use the gel as the only method of contraception, and then after 1 year, they go to the recovery phase, and we monitor them as long until they finish recovery. So the couples committed for 2 years, and we enrolled. The goal was to enroll 420 couples, and we need 200 to complete 1 year of efficacy. And this, as you can see in the map, this was done in 17 centers in 4 continents, including the center in Santiago. So the primary endpoint is the prevention of pregnancy in a female partner. The others, including safety, adverse events, acceptability, and the suppression of the hormones and sperm count. But the primary endpoint is whether it can prevent pregnancy in a female. Next slide. So we completed enrollment in 2022, enrolled 462 couples, and then everybody entered efficacy in about December 2022. And therefore 1 year in November, December 2023, everyone, or beginning of 2024, everybody completed efficacy. And by the end of last year, we completed a recovery. The data is still being analyzed. The data is sort of very promising, and we are not allowed to give the results. And I can show on the next slide that preliminary data suggests it's very effective, it's reversible, it's safe, it's acceptable by both partners, and we think it's accessible. So what is being planned is that we plan that the manuscript is being written, being analyzed, and the summer of 2025 submitted for publication. They are, in the meantime, they're planning a multi-center phase 3 study, and they will seek guidance from the FDA in the last quarter of 2025, because the clinical study report has to be submitted, and that's the time it will be submitted. In the meantime, phase 3 protocol is being drafted. The gel manufacturer has to be found, identify and pre-qualify sites. It's believed that we will be able to start the phase 3 study probably towards the end of 2026. And this has been delayed with the data analysis, and delayed because of FDA wanted us to do some preclinical studies. So it's hopeful that it will start, and if it is approved, it will be the first reversible hormonal contraception. Next slide. I'm going to run through these two slides very quickly. It shows on the right-hand side the hormonal methods. The first rectangle is what we talk about, the hormones and the new hormone methods. Is only one of a few. So there are new things to block sperm transport, and these are devices where you can inject into the hydrogel into the vas deferens, and you cure in place, so it blocks sperm transport. And many people are working on post-testicular maturation, sperm capacitation, motility, and sperm function, and none of them are in clinical trials, but we know that the SAC inhibitors and API they have been planning in clinical trials. And then there are the spermatogenesis inhibitor, which works targeting on the testis itself without affecting the hypothalamic pituitary axis. And one of them is in clinical trial, which is the retinoic acid alpha inhibitor. Next slide. I'm going to done. This is a VAS. This is a hydrogel. Hydrogel is injected into the VAS. I thought you guys would be interested in. It's cured in place. It became solid. And then when you want to remove it, you inject a solution to dissolve it, and then the VAS becomes patent again. So it's a reversible VAS occlusion. Next slide. So these are the reasons why that has been claimed that it took so long for us to have a male contraceptive, but many of them, I think we are slowly resolving it, and we believe that in the near future, the hormonal male contraception is going to go first, followed very rapidly by the methods that target the testes, followed by and also the VAS occlusive method. Thank you very much. Sorry about the problem. So this is all you want to know. If you want to, everything is in a publication that came in Andrology in 2024, and we have lots of people writing that. There's 16 chapters and talked about all aspects of male contraception, and every manuscript is free. Thank you so much. Sorry for taking so much time.
Perfect. Thank you very much, Christina. An excellent presentation as always. I will ask the public if anyone wants to ask you something. ¿Hay alguna pregunta para Cristina? La pueden escribir en el chat que tienen en YouTube, si tienen alguna pregunta. Si no, ya podemos pasar a la segunda presentación de esta noche. Well, it seems, Christina, that everything was extremely clear.
Good.
So there are any questions. So thank you very much.
Thank you, Dr. Vinay, Jose. It's wonderful talking to you. Anyway.
Thank you very much, Christina. Have a very nice afternoon.
Okay, thank you so much. All right.
Thank you.
Bye.
Bye. Bueno, esa fue la presentación de Cristina y ahora será bastante corto. En 20 minutos les quiero actualizar acerca del deterioro de la fertilidad masculina en las últimas décadas y cómo esto se asocia a otras enfermedades. Así que déjenme compartir mi pantalla. Entonces, ya, perfecto. Entonces hoy hablaremos acerca del deterioro de la calidad seminal y el síndrome de disgenesia testicular. Como ustedes sabrán, la mayoría de los países desarrollados, y aquí también incluyo a Chile, ha presentado una disminución en sus tasas de fertilidad de forma muy severa. Países como Japón, países de la Unión Europea, Corea del Sur, están todos bajo la tasa de fertilidad de 2,1, que es la tasa de fertilidad que permite que una población se mantenga con un número estable. Cualquier tasa bajo 2,1 hace que la población disminuya. Y paralelamente a esta disminución de la tasa de fertilidad, que tiene múltiples razones económicas, sociales, también se ha visto un deterioro extremadamente severo de la calidad seminal. Aquí pueden ver en este gráfico, podemos ver aquí el gráfico, la línea azul, que son países occidentales. Pasamos de una concentración promedio de 100 millones de espermatozoides por ml en los años 70 a menos de 50 millones en el año 2010. Es decir, en 40 años hubo una disminución de más del 50% de la calidad seminal. Esto también se refleja, de hecho acá estoy citando un artículo de la doctora Wang. Esto se ve no solo en concentración, como lo pueden ver en este gráfico, sino también se ve en espermatozoides mótiles progresivos o en cantidad total de espermatozoides. Es decir, una disminución severa en todos los grupos etarios. Y aquí mismo podemos ver que la concentración promedio en los años 80 era de unos 92 millones por ml y en la década de 2010 alrededor de 60 millones por ml. Y lo más peligroso es que la velocidad de deterioro está aumentando. Si bien en los años, antes de los años 2000, es decir, desde los 70 hasta el 2000, existía un deterioro, la velocidad de deterioro era aproximadamente de 1,1% por año, versus el deterioro que existió después del año 2000, donde la velocidad de deterioro es mucho mayor, alrededor de un 2,6%. Aquí podemos ver cómo el deterioro de la concentración espermática o deterioro del número total de espermatozoides en la muestra seminal ha aumentado la tasa de velocidad del deterioro cuando nos estamos acercando más a la época actual. Y existen también otras diferencias en la calidad seminal. Existen países o etnias con diferentes concentraciones espermáticas y también existen cambios estacionales. pareciera que en invierno los hombres tenemos una mejor calidad seminal que en verano. ¿Y por qué? Existen múltiples teorías de por qué se ha deteriorado tan intensamente la calidad seminal en las últimas décadas. Existen factores maternos, como por ejemplo hábitos tabáquicos, alcohol, fármacos maternos, que deterioran la calidad seminal del futuro hijo. Y existen factores medioambientales de la exposición del embarazo. Y nos vamos a concentrar bastante ahí porque el factor más estudiado son los llamados disruptores endocrinos. Aquí existen mecanismos como son los disruptores endocrinos o mecanismos tóxicos directos sobre el feto. Y esto va a llevar, como vamos a ver más adelante, no solo a un deterioro de la calidad seminal en esos adultos, sino en otras enfermedades relacionadas con el desarrollo sexual de estos hombres. Si bien hemos mostrado que la calidad seminal ha ido empeorando, ¿qué otras cosas han pasado más o menos con las mismas velocidades? Podemos ver acá cómo las tasas de cáncer testicular han ido aumentando en frecuencia de forma muy intensa en los países europeos, en los países americanos. Además, las tasas de hipogonadismo o de otros signos de hipoandrogenización, como es la criptorquidia, han ido aumentando mucho. Miren aquí, acá tenemos promedios de testosterona plasmática en los años 80, en los años 90 y en los años 2000. Podemos ver que los hombres de los años 80 tenían mejores testosteronas que las que tenemos ahora. Y las tasas de criptorquidia en diferentes países han ido aumentando. Es decir, tenemos un deterioro de la calidad seminal y un aumento en las tasas de cáncer testicular, hipogonadismo y signos de hipoandrogenización embrionaria, como es la criptorquidia. ¿Y qué puede estar explicando todo dentro de un contexto sindromático? Esto es bien interesante. Todas estas cosas que yo les he dicho, como disminución de la calidad seminal, criptorquidia, hipospadias, que es otro signo de hipoandrogenización embrionaria, y cáncer de testículo, no solo podemos ver que tienen la misma tendencia en ir aumentando, sino que podemos ver que se agrupan en poblaciones. Por ejemplo, en Dinamarca, tenemos un gran deterioro de la calidad seminal y también altas tasas de estos otros hallazgos, mientras que en otras poblaciones tenemos una mejor calidad seminal y menores tasas de estos signos de hipoandrogenismo. ¿Y cómo entonces podríamos explicar esto? Bueno, es justamente en Dinamarca donde este problema es tan importante que se acuñó por Skakebeck hace ya más de 20 años el término de síndrome de disgenesia testicular, que es una alteración del desarrollo gonadal masculino, tanto de las células que darán espermatogénesis como de las células que producen testosterona. Y por lo tanto, en estos adultos y niños también, tendremos signos de alteración de las células germinales y tendremos signos de hipoandrogenización como criptorquidia, hipospadia, hipogonadismo en la vida adulta. Este es un muy bonito esquema que publicó Skakebeck hace 10 años, donde podemos ver los diferentes disruptores que pueden ser tóxicos durante el embarazo y otros factores de riesgo, que alteran los dos grupos celulares, las células germinales y las células de Leydig. Con la alteración de las células germinales llegamos a dos grandes problemas: baja producción de espermatozoides y alteraciones en la duplicación de estas células germinales y mayor riesgo de neoplasia germinal in situ, el antiguo carcinoma in situ testicular, y mayor tasa de tumores de células germinales. Y en la alteración de las células de Leydig tenemos una hipoandrogenización embrionaria, lo que nos lleva a más tasas de criptorquidia, hipospadia, baja producción de testosterona y también disminución de la distancia anogenital. Como dije antes, hay muchas explicaciones de por qué hoy los hombres tienen una peor calidad seminal que antes. Tóxicos, obesidad, dieta, enfermedades crónicas. Pero los disruptores endocrinos, tanto en la vida adulta como en el desarrollo embrionario, juegan un rol muy importante. Los disruptores endocrinos son moléculas que alteran ejes endocrinos y llevan a enfermedades. Se clasifican en dos grandes grupos: los disruptores endocrinos con actividad estrogénica, como el dietilestilbestrol, el bifenol A y el estinilestradiol, y los con actividad antiandrogénica, que son los talatos. Estos actúan en diferentes niveles del eje hipotálamo, hipófisis, testículo. Se pueden ir a todas las flechas rojas, que ahí estamos viendo daño por disruptores endocrinos. Pueden bloquear el eje hipotálamo hipoficiario, pueden bloquear el receptor de LH de las células de Leydig, pueden bloquear la esteroidogénesis, pueden bloquear al receptor de andrógeno, pueden bloquear al receptor de FSH de las células de Sertoli y pueden dañar directamente los espermatozoides. Este síndrome de digenesia testicular, al ser extremadamente complejo, es muy difícil estudiarlo. ¿Por qué? Porque en humanos tiene tantas aristas, puede demorar generaciones en ser provocado, que es muy complejo hacer estudios en humanos. Podemos solo hacer estudios poblacionales como los daneses, pero esos estudios tienen limitaciones, hay muchos sesgos y existe falta de evidencia mecanística, es decir, causa-efecto. Y al revés, en los estudios en animales o in vitro, sí nos pueden dar causas un poquito más mecanísticas, es decir, nos pueden dar una mayor relación de causalidad, pero muchas veces no son tan extrapolables a humanos. Así que es muy difícil estudiar el síndrome de digenesia testicular. Un gran ejemplo para estudiar el síndrome de digenesia testicular son nuestros pacientes azospérmicos. Los pacientes azospérmicos, que nosotros les hacemos una biopsia testicular para extraerles espermatozoides, también aprovechamos de enviar material anatomía patológica. Y en una proporción de estos pacientes encontramos neoplasias germinales in situ. Este es un caso clínico que publicamos ya hace algunos años, donde este hombre no tuvo una recuperación espermática adecuada, pero sí tenía en el revestimiento de los túbulos seminíferos células con marcadores de neoplasia germinal in situ. Y este hombre fue sometido a radioterapia testicular después de ser presentado a un comité oncológico. Es tan así esta asociación del síndrome de digenesia testicular que hace algunos años se cambió la clasificación de tumores testiculares y los tumores de células germinales, que son más del 90% de los tumores testiculares, ahora se subdividen en tumores derivados de neoplasia germinal in situ y los tumores no derivados de neoplasia germinal in situ, que es el tumor de células germinales infantil y el tumor espermatocítico. ¿Y por qué? Porque los tumores de células germinales que nosotros estamos acostumbrados a ver provienen de células germinales sanas originalmente, que sufrieron una noxa, tanto genética como ambiental, que los llevó a diferenciarse a seminoma, y algunas veces se lleva a cabo una diferenciación somática que lo lleva a las otras estirpes celulares. Entonces, acá arriba tenemos un hombre normal que de una espermatogonia que entra posteriormente a espermatogénesis, vamos a llevar a espermatozoides maduros. Pero, por razones genéticas y por factores exógenos, entre ellos los disruptores endocrinos, podemos tener una célula con una mutación en su ciclo celular, que será un pre-neoplasia geminal in situ, que al proliferar nos llevará tanto a seminomas o no seminomas. Esto también se ha llamado la teoría de los hits, que se necesitan múltiples daños para que ocurra esto. Puede haber primero puede haber un factor de riesgo genético, pero posteriores daños nos van a ir a hacer avanzar en esta oncogénesis. Esto lo acabamos de presentar en el Congreso Americano de Urología y, como les decía, no solo hay azospermias con neoplasia geminal in situ, sino que ya hay azospermias con tumores testiculares. Y esto es nuestra experiencia de 12 pacientes que se presentaron con un tumor testicular y azospermia, y les hicimos una cirugía doble de orquiectomía, pero a la vez de TESE, de Testicular Sperm Extraction, para criopreservarles espermatozoides. Lo que les quiero decir que existe una asociación entre hombres infértiles y cáncer testicular. Esto es una imagen bien compleja de diferentes factores genéticos de la oncogénesis del tumor testicular, pero solo les quiero hacer énfasis sobre todo a los que nos están escuchando que se dedican a la andrología, que una de las pruebas genéticas que nosotros pedimos habitualmente a hombres infértiles, que son las microdeleciones del cromosoma Y. La mutación GR es una mutación específica de ACFC. Es no solo un factor de riesgo para infertilidad, sino que es un factor de riesgo para cáncer testicular. Ya estamos terminando. Este es un estudio reciente brasileño donde graficaron las tasas de sobrevida libre de recurrencia y sobrevida libre de cáncer de hombres con cáncer testicular y los separaron en dos grupos: hombres con un cáncer testicular aislado u hombres con un cáncer testicular en el contexto de disgenesia testicular, es decir, hombres con criptorquidia, hipospadia, etc. Y podemos ver que el pronóstico en este grupo de pacientes es mucho peor si es que un hombre tiene, además del cáncer testicular, el contexto de un síndrome de disgenesia testicular. También tanto para sobrevida libre de recurrencia como sobrevida libre de cáncer. O sea, podría el síndrome de disgenesia testicular empeorar el pronóstico del cáncer testicular. Y ya para ir terminando, este es un estudio que acaba de ser publicado hace unos días atrás, y es un estudio gigante danés de 78.000 hombres, un estudio retrospectivo, que analizaron la mortalidad en hombres con alteraciones seminales y sin alteraciones seminales. Vámonos, por ejemplo, aquí a concentración seminal. Hombres azospérmicos o con oligozoospermia tienen una mayor mortalidad que hombres normozoospermicos. Y lo mismo con los otros parámetros del espermiograma. Esto tiene muchas otras causas, como estilos de vida. Existen muchos factores como el tabaco y la morbilidad y la enfermedad cardiovascular que afectan tanto la fertilidad como la sobrevida. Pero es un reflejo de que tenemos factores que no solo causan infertilidad, sino que también causan otras enfermedades en el hombre. el síndrome de disgenesia testicular sería una forma leve de otros trastornos del desarrollo sexual, siendo, por ejemplo, una forma severa, un hombre que nace con genitales ambiguos, que eso demostró mucha hipoandrogenización embrionaria, pero al otro extremo tenemos un hombre solo infértil que tiene una forma leve de este espectro de disgenesia testicular. Y esta disgenesia testicular se va trasladando a las siguientes generaciones. La generación 1 tal vez va a tener el primer daño y va a dar una generación 2 con una alteración seminal leve, y la tercera generación ya va a tener una alteración seminal muy severa. Y eso es la llamada deriva epigenética. Y ya la última diapositiva refleja que con una tasa de fertilidad de 2,1 se mantiene el tamaño poblacional, pero por ejemplo, con una tasa de fertilidad de 0,8, ya después de 3 generaciones, una población podría desaparecer. Por lo tanto, esto es un tema muy, muy importante. Muchas gracias. Bueno, esa fue la presentación. Espero que les haya gustado. Espero que la hayan encontrado interesante. No sé si alguien tiene algún comentario o pregunta por el chat. Pareciera que no. Así que muchas gracias por conectarse y quedará grabado todo en el canal de YouTube de la Socmer para que puedan revisarlo cuando quieran. Buenas noches.